begin, traditional owners of the First Nation people of the lands upon which we are meeting from different parts of the world. Welcome everyone to this session. Today's session, the topic is mental health for all. It's a universal human right. So this topic has been organized in the backdrop of this year's World Mental Health Day theme. And in this session, I have the privilege of having some eminent colleagues from the specialty of mental health and also a special guest, Sri Prashant Nair IAS. He would be joining soon. He has been busy, but at any time from now, he would be joining. But we would start with the specialist. Um, so the importance of mental health. So mental health is as important as physical health. We know that it is um, very related, especially in the modern world. It's taking significant space, especially what is happening around in the recent days. We are all stressed about what's happening in the world, especially in some parts of the world. There are people who are really distressed. So this is a time it's important that we talk about mental health. So according to the World Health Organization, so mental health is a state of well-being that enables people to cope with the stresses of life, realize their abilities, learn well, one work well, and contribute to their community. So it is all encompassing. So both mental health and physical. So we often tend to ignore our mental health because we give always importance to physical health. Partly the reason is about the stigma around mental health. When we talk about mental health, it's always having a negative connotation. So mental health goes traditionally, and even in today's world, in most parts of the world, including in the Western world, um, it has got a negative connotation that it is mental illness. We we talk about mental illnesses and mental health issues. So we have mental illnesses that are diagnosed as per the classification of International Classification of Diseases called ICD-10 and DSM-4, that is followed by the United States. But mental health issues is a very broad one, especially the stress, anxiety, and depression. They are very common. But we don't, or people don't generally give importance to mental health. So there is a lot of emphasis and conversation these days about raising mental health awareness. Um, so we have there is a campaign called "Are You OK" in Australia. So similarly, there are different campaigns in the world in raising awareness. For example, about raising men's awareness, there is a program called November, so which is going to start from 1st of November. So men grow mustache and as a symbol of raising the awareness. So there are various campaigns that happen in different parts of the world. But one thing is very clear that mental health is equally important as physical health. Um, so we have the panelists with specialities in different areas of mental health. So in mental health interventions, what we generally adopt is a multidisciplinary approach. So we call us biopsychosocial model. So bio means medical interventions. Psychological is more psychological oriented, various therapies like psychotherapy, behavior therapy, family therapy, and social includes the family and the social network and the connections with family, friends, and the community. So it is that model is being followed, and accordingly, a mental health team includes a psychiatrist, a clinical psychologist, a psychiatric social worker, and a psychiatric nurse. So this is what. So this is a teamwork, and that is what. So we represent, this panel represents all these multidisciplinary themes, and we have in our panel Dr. Shabir Amanullah. Dr. Shabir has done his diploma in psychological medicine from the Central Institute of Psychiatry, Ranchi, India, and his MD from the National Institute of Mental Health and Neurosciences, Bangalore. He was awarded the gold medal in his MD. He worked in India and then he went to UK, where he completed his MRC Psych and specialized in adult and geriatric psychiatry. Later, he moved to Canada. Currently, Dr. Shabir working in Canada. He used to work in Prince Edward Island initially, and then he's currently the chief of psychiatry for the province before leaving in 2012 for Ontario. So he worked in Woodstock General Hospital as the chief of psychiatry until recently becoming the chair of geriatric psychiatry and clinical director at the Queen's University. Dr. Shabir is currently the president of the Canadian Academy of Geriatric Psychiatry, the president of Oxford County Medical Society, as well as the chairman, scientific chair of the Indo-Canadian Psychiatric Society. He's also the program chair for the Ontario Medical Association section of psychiatry. Dr. Shabir has done many awards, including the Distinguished Fellow of the Canadian Psychiatric Association. He was presented the Outstanding Contributions to Geriatric Psychiatry Award by the Canadian Academy of Geriatric Psychiatry. Dr. Shabir has published content in a number of peer-reviewed journals, written chapters, published a book, Complex Clinical Conundrums in Psychiatry. His research interests include physician burnout, ADHD, and autism in the elderly, PTSD in dementia, and cannabinoids in dementia. Dr. Shabir has presented his research at various conferences around the world and encouraged many students to get into research, both present and publish. I would invite Dr. Shabir to speak on today's topic for mental health for all, and with special reference to his area of specialty, the geriatric psychiatry. Dr. Shabir.
Hello, everybody. It's a delight to be here, but I must start off with an apology to all cricket lovers. Sincerely, we feel bad about this, but we somehow have managed to put all this together under Josie's aegis and platform. So kudos to him for bringing us all together. I'm hoping that we will still get to enjoy both the cricket match and enjoy this session as well. Geriatric psychiatry is obviously a subspecialty, and it's growing rapidly across the world. The reason that Josie wanted us all to have this session is primarily because of the need for us to acknowledge the importance of mental well-being. We often have this notion that when you see a psychiatrist, you see them because you have a mental health issue that's very severe that requires medications. That you have bipolar disorder, schizophrenia, or you have something more severe or something milder but requires medications. The truth is, psychiatrists as a group understand both physical and mental health extremely well. We know the biological basis of illness. We also understand the psychological manifestations of illness. And we do the best to make these come together so that you get very holistic care. And there's a very big misconception that leads on to stigma that agar aap psychiatrist ko milenge to aapko kuch badi bimari hai. This is not true at all. We see many people who we tell them कि आपका वैसे कुछ बीमारी नहीं है, you're fine, you should not really be struggling or worrying about this. We would advise you to probably change your lifestyle. We do that as well. The notion that we somehow give pills and that's all we do is wrong. Why this came about was this big push towards establishing asylums and mental hospitals where patients were treated exclusively within the confines of a hospital. Those have changed. Now we treat people in the community, treat people at home, and the emphasis on treatment has become very holistic. So if you look at the merging of traditional ways of intervention, like whether it's yoga, Tai Chi, these have made its presence felt in psychological interventions, not because there was any profound and solid research at that point in time, But because we realize that sometimes when you lead a lifestyle that's unhealthy, you create mental health problems. Mental health problems can be varied. So we know now globally there's lots of things going on. People are worried, people are anxious, people take sides. We do all kinds of things in life, but that's human. That does not make you abnormal. That does not even remotely mean you're a psychopath or you have some kind of personality disorder. Human beings by nature are programmed to do that. What we need to be cognizant of is the impact it could potentially have on your own mental well being to the point where you're not sleeping well, you can't eat, you're losing your friends, you're getting into acrimonious arguments and debates over something that doesn't concern you. Where does geriatrics fit into this whole thing? It's very simple. We are all getting older. By by the very definition of the fact that you're born, you know that we're going to get older as time goes on. Some of us are fortunate that we get older and we live in environments that are peaceful, that are nice. You have friends. You know, I was very fortunate. We studied at the Central Institute. I had very good friends. They're all here today. I'm not too sure if we have exactly the same environment today or we don't. The point being, if you take those memories that are pleasant and happy and you create those memories, as you get older, you have things to look forward to. Mental well being is crucial. If you have a very physically able body, no disease, but you have sadness and depression, your well being is of not much use because you can't enjoy it. At the same time, if you look at someone like Stephen Hawking, who literally had physically, he has nothing. But if you look at what he's achieved, it's fairly profound and it puts many other people to shame. How was he able to do that? Some people argue that it's probably resilience. Others argue that he had this focus, that he decided he wanted to do something. Well, if he did, what's stopping us from doing it? The point is, we waste a lot of energy. You know, Josie was reading out that I do this, I do that. I do a lot of things, but I'm sure there are many people who do just as much. There's a common comment that you must be very intelligent. Only I know how intelligent I am or how lacking I am in intelligence. The point is, you need to make use of time. You build on your strengths, you build on your capacities. And as you get older, you truly do become wiser. You find that many of the things you would have objected to earlier, now you know it's not worth your while. Many of the things that would have upset you, now you look at it and know that in the next few days it's going to go away. You recognize things that actually make you feel easier as you get older. It's called wisdom. But to accrue wisdom, you need knowledge. To accrue knowledge, you need to have an open mind. To have an open mind, you need to have a good environment. To create a good environment, you need platforms like this that help you recognize what is a positive environment and what may not be a negative environment. I don't want to labor too much about mental well being because I know my colleagues will have things to say as well. But what I will say is my connectivity is not very good due to certain technical issues that other panelists know about. So you will probably not see me on camera, but I will still be available and I'll pass it back to Josie so that he can get other panelists on board. Thanks, Josie.
Thank you, Dr. Shabir. That was a good overview. And next, would like to ask, or our next panelist is Dr. Sonia. Dr. Sonia Pariel is a consultant psychiatrist and director of Dhanvantari Hospital, a 36-bedded inpatient hospital at Raipur, providing mental health services to the state of Chhattisgarh in India for the past 24 years. Dr. Sonia completed her MBBS from Gandhi Medical College, Hyderabad, and her postgraduate qualification MD in psychiatry from the Central Institute of Psychiatry, Ranchi, India. Dr. Sonia is very passionately involved in raising awareness on mental health issues at the state, national, and international levels. Dr. Sonia has been involved in the training of health workers, doctors, and obstetricians in areas related to perinatal mental health in Chhattisgarh through the district mental health program and national mental health program. She is the chairperson of the Indian Psychiatric Society Task Force on Perinatal Mental Health and past chairperson and convener of the Task Force on Women's Mental Health. So Dr. Sonia's specialization is perinatal mental health and women's mental health. Dr. Sonia has been the past president of the Chhattisgarh Psychiatric Society And she has various publications in the areas related to women's mental health at the national and international levels. She has been awarded the most popular woman doctor in Raipur in 2010 and the outstanding lady in the field of medicine in Chhattisgarh 2017. Dr. Sonia, most welcome to the session, and I would like to have your views about mental health for all in general, with special emphasis on perinatal and women's mental health that are still far behind generally in the world, especially with reference to India.
Thank you, Josie, for giving all of us this opportunity to interact with the audience today on a very important issue. That's mental health for all. I mean, let me share with you some personal experiences. As a psychiatrist, when I entered into this field, the concept of anybody going into psychiatry was that, the person who treats mentally ill patients uh, will not be that great a success because these illnesses, they never improve, and they have very long durations of treatment, and all kinds of modalities of treatments are used with such patients without much good result. This was the concept of psychiatry 2.5 decades ago when I joined, and everyone, why do you have to take psychiatry as a branch? But let me be positive and let me tell you that mental health provision, treatment of mental health issues has improved drastically in the last 2 decades. A lot of research, a lot of good work, a lot of teamwork, and we have most of our patients now coming back to their normal lives. I mean, I can share with you, we have engineers, doctors, we have social work, people with all walks of life having mental health issues, but going back to work, going back to their functionality a great deal. But what we need to focus today, taking off from where Dr. Shabir left, what do we know about mental health? Why does this illness occur in the first place? There is so much of misunderstanding regarding how mental illness occurs. The biopsychosocial model of these illnesses, in fact, went into some sort of controversy that, are we not sure? We are having so many theories about the etiology of this illness. But yes, our genes and environment, there's a lot of interplay, and the psychosocial and the cultural issues which come into play in a genetically vulnerable person can lead to a whole spectrum of disorders. And once we understand that the brain is a very, very important part of our body, just like your eyes or liver or heart, we need to give this message across to people that the brain is an organ and it can have disturbances. There can be disturbances which can lead to illnesses. And of course, the cultural factors, the environmental factors, the social factors, they come into a lot of interplay with the genetically vulnerable person who can have an illness. So we need to explain this in a very simple way to our lay public so that they reach the doctor in time for treatment. Shabir was worried about the stigma and the obstacles that are faced. I faced a lot of challenges when I started my practice in related to issues related to women, especially during pregnancy and the postpartum period. It was assumed to be a period of emotional bliss. A mother has to be happy during this time. How can she be depressed? Pregnancy is a miracle kind of a thing happening. You're going to give birth to a baby, and then to try to convince the family that this lady is depressed or anxious and she needs help, she needs all kinds of help so that she can have a healthy baby, and to explain to them that what impact a mental health issue during this period, not only on the mother but also on the infant. So this mother infant diet is so crucial during the perinatal period, and that is what inspired me to interact with my obstetricians, the health workers, and we had a lovely relationship with our state government, which, I had a lot of IS officers, especially women, who are very proactive in this area, and who we worked as a team to bring about increased awareness that, even illnesses like anxiety or depression or even minimal amount of stress, leave aside the core psychotic illnesses like schizophrenia and bipolar, even these mild spectrum disorders, if we don't intervene early, they can have a very bad long term impact on the fetus and the infant and the child, on the adolescent later on. So we need to provide interventions early. We need to intervene as early as possible to have better birth outcomes. And that can only happen if we work in a team. unless we sensitize our government workers, unless we interact with our policy makers, then what is the impact of poor mental health, we are not going to get success. So I think that the first step, like what Josie has initiated, increase awareness about mental health issues. It's so important. We need to talk about it. There are a whole spectrum of disorders, and you need to explain and reach out, to the people in a very, what should I say, simple manner. Explain to them the medical model as well, and also explain what are the cultural factors, social factors which are implicated. Now it is so well established that perinatal depression, whether it's in the antepartum period or the postpartum period, lack of psychosocial support is one of the very high risk factors. Unplanned pregnancy, poor marital support, and the loss of interconnectedness of the family. In India, I don't know about the West, but in India, we are suddenly finding a lot of migration from the rural to the urban area. And suddenly, our family support system, which was so protective for mental health, suddenly it has disappeared. You find women who are pregnant living alone in a room, nobody to take care of them, whether it is a village or whether it is in the city, and the kind of stress the primees face, that how they're going to handle their first pregnancy, it is tremendous. So even if somebody just connects with them, reaches out to them, talks to them, lot of stress comes down. And we need to address this issue from a very holistic manner. And like Josie rightly pointed out, that to intervene medically, socially, psychologically, all teamwork is so important to improve mental health, especially in the perinatal period. And a lot of research also needs to be done in this area, because this is the window period, where we can find out why illnesses are beginning. So many illnesses are happening the first time in the antepartum period. And in the postpartum period, we see first episode psychosis. In developing countries, we are seeing a high degree of psychotic patients, which means they have lost reality contact. And you need to really save them, because in areas like where I'm practicing in Chhattisgarh, there is lack of knowledge. People go to faith healers, they will do stalking, they won't understand the medical model at all. So there again, we need to bring about awareness, remove the superstitions regarding the aspect of mental health issues. So that's what fascinated me to delve into this area. And I was so happy when Josie said that we can reach out through many platforms to increase awareness on this. And I thank Josie for giving this opportunity. I hope we have a good interactive session today to reply to people's concepts, or like how they understand mental health issues, and what kind of treatments that they should be taking, and without feeling stigmatized, or without feeling experiencing any obstacles to reach the team in time. So thank you, Josie, for giving us, all of us, this opportunity to interact with you all today.
Thank you, Sonia, for that introduction. I think we will continue the interactions further when we have one round with all the panelists, and then we'll take some questions from the audiences who are watching all over the world. Some of the questions, and then we will come back again. Next, I would like to introduce the panelist, Dr. Soumya Basu. Dr. Soumya Basu has done his post-graduation diploma in psychological medicine and MD in psychiatry from Central Institute of Psychiatry, Ranchi. Dr. Basu is a child and adolescent psychiatrist with more than 20 years experience. He is also an associate professor of psychological medicine at the Monash University. Dr. Basu is a consultant and a psychiatrist at the Monash Health. He is consultant in charge of the neurodevelopmental assessment team, which caters to the assessment and neurodevelopmental disorders from the age of 0 to 25 years, and also works with the core treatment team. Associate Professor Basu is the coordinator of the Monash University Child Psychiatry Online Registrar Training Program and the chair of Monash Neurodevelopmental Interdisciplinary Research. He has also had a private practice for more than 12 years and has adult patients he has taken care of since childhood. Dr. Basu has been practicing in Australia for about 20 years now. Dr. Basu, probably you can correct me. Over to you, Dr. Soumya Basu.
Thank you, Joshi, and lovely to meet the panelists as well. They're, friends for a long, long time. And the other thing I'm really interested in is exactly where Sonia's area of interest is perinatal psychiatry. I'm a child psychiatrist working from a mother-baby in mother-baby units. I'm in charge of a mother-baby unit as well in my private practice, where I come from the infant mental health perspective in the dyad. And my big area of interest is also parents with mental illness. Um, so, um, in child psychiatry, it is one of those areas where this biopsychosocial model is always extremely at play, and the multidisciplinary approach is very important, where we closely work with psychologists and occupation therapists, speech therapists, and social workers. And uh, as you can imagine, in the Western world, the because of the social turmoil, because of social disconnection, capitalism, don't know. I mean, the incidence of mental illness in children are going up in geometric proportion. The pandemic and the post-pandemic times have shown how there is this catastrophic increase in school refusal, eating disorder. Um, I don't know what happens in India, but uh, the how the pandemic, the second pandemic after the pandemic is the mental health crisis. Australia is a very well-resourced country. Despite having all the resources, the demand is so much that we'll not be able to meet up with the demands. For example, school refusal, which is seen as a psychiatric emergency in children, have increased 4 times after the pandemic. Um, from a mental health point of view, um, from training perspective in child psychiatry, when I was 20 years ago, there was no proper training, proper postgraduate training in child psychiatry. The training in itself in India is still in its nascency. Only few places have got a child psychiatry advanced training program. And the immensity of the problem is that 50% of population under the age of 18 is in India, and the mental health impact of that it's quite scary. As Sonia was saying, that how the families are changing, how the socio-demographic profile is changing. In the past, it needs a village to raise a child, and as the village is disintegrating, the if and as India is progressing towards the Western values, impact would be on children, and then that is often seen as if you think about the Western perspective with all its prosperity, the mental health problems in the West in children it's about 25%. So if that happens in India, I don't know whether the psychiatric services there would be able to cope with the problem. Um, I think with that, I will pass it on to you, uh, uh, and thank you for this opportunity.
Thank you, Dr. Soumya. That was a good overview, especially in relation to children. I think I will come to that later because I haven't introduced myself. I thought I would do it later, what I do, because where my focus has been on children. But I'll come to that after going to Gayatri. Gayatri Sita Narayan is a consultant clinical psychologist at LifeSpace Institute of Mental Health, a venture she has established to undertake her own private practice in Kerala. Gayatri has done her master's in psychology and MPhil in clinical psychology from Central Institute of Psychiatry, Ranchi. She's also a PhD scholar. Kathy, over to you. Give us or give the viewers an overview about what a clinical psychologist does in that multidisciplinary team and in that biopsychosocial model.
Thank you, Josie. Thank you, everyone. Our, as my role as a clinical psychologist in the term is to work with the team. For example, it would be a multidisciplinary approach where a psychiatrist would be taking care of pharmacological treatment, and social workers would be dealing with the social aspects of mental health issues. And basically, as a clinician, even though we focus on biopsychosocial model, when clinical psychology, it's mostly the basic tenet of working is psychotherapy. Like most people say that, okay, what's, we just talk, and how just talking is gonna reduce the problems. What are you people doing except just talking? That though our friends also does, or I sometimes talk to myself. So psychotherapy is actually not just talking or giving some advices, like telling sab theek ho jayega, everything will be all right. Nothing like that. It's a scientific stream where lots of researchers and have been put into certain manuals, modules of therapy. Like, for example, I'll give you an example. Like if you're born, somebody, fall and their bone got broken. What we generally do, you'll go to an emergency, and X-ray will be taken. People will give you medicines, and then according to they will assess, okay, whether it is broken, whether the bones are broken, or it is just like ligament tear, or the physician will assess, and then they will decide whether they should put your leg into, what kind of plastering, casting, or whatever treatment they give. Likewise, consider that mind. When I say, it's like, as people who talked before me beautifully put, what is the importance of mental health? Like mind is like that, that juncture of, like, motherboard of your you as an organism. Like, what computer motherboard does to computer, mind is like that, like all controlling, which decides everything. It's a culmination of the thoughts, consciousness, and all those things. So what mind does is, when mind feel like, if 3-4 incidents happen, we may feel like, oh, everything is going low, and then you will start making misconceptions about, so then my life will be all stale, or it's going to be dull, or then it can manifest into certain mental health issues. So what a clinical psychologist does is exactly like how the bone break, like we do assessments. So as we rightly know, we don't, there are no X-ray machines no machine have been found which can do some, which gives X-ray images. So what mental health experts does is, we do certain assessments, we assess, and we find out, like what X-ray does. There will be very structured questions, interview, all those tools, which give us very scientific, evidence-based conclusions about the diagnosis. Then we do the treatment. Like, we will assess multiple factors, like severity of the issue. Like, for example, if we just hit our leg in somewhere and it's just swelling, there are no other issues, your physician would just give you 2 days painkillers or something, and you take rest or something. But if leg is broken, they will tell you to take rest, put your leg in plaster. Likewise, the mental health expert team will make a plan. It's called therapy plan. So the therapy plan will include it is based on multiple things. Okay, like, okay, the severity, and your coping mechanisms, and it's a very broad area. So then the physician, that team, mental health team, will make a therapy plan for you. So therapy plan, when I say the therapy plan, A clinical psychologist would feel like, okay, this is severe depression. I'm giving you an example. Okay, my client would really do well with medicines. So then we will give sessions to increase the medical compliance. We will do behavioral interventions, and we will do issues, whatever, based on the chief complaints, the problems, main concerns which our client has. So that is what happens. And to do that, like, like in every emergency medicine, every system, there is a standard operation procedures, like okay, people have materials. Okay, do you want to bad, according to the severity, they will decide whether you just want some pain ointment or whether you want plaster in your leg. Likewise, we also decide that, okay, which therapy will go with it, with the nature of the issues we are having. That being said, I just want to add just 2 more minutes about the focus and my amazing panel, which already discussed about what is important, what is mental health and importance of mental health and the right of it, rights associated with it. And they have also shared how it is, why it is important. It's important in different age categories, in special population, etc. I just want to focus on that again, mental health as a universal right. I just focus on how we will assert our right, not how with the people who have different challenges, how you are going to assert your right. So, the right we can assert by just watching away some videos and just say that, okay, everything will be okay or not, or it has a, it's up to that voluntary choice of a person. But when we assert our mental health rights, it should be very important that the system, when I mean system, the society or the government should provide, and we are supposed to get the best treatment, like the proper treatment, optimum treatment. What is proper treatment? It's the perfect temperament. Where whether it is pharmacological treatment or the psychotherapy treatment, it's counseling, or it's just about psychological education, psychoeducation, or any treatment, it should how the right should be. People have the right for scientific temperament. You need a mental health expert who has scientific temperament. It's not like, okay, I face these issues, so you also, it's okay, you just have. That is where people don't when we say that everyone has universal right for properly trained mental health experts, not just motivation guru who just have some online quack degree. And people deserve, they have the right to have clinicians who have access to latest researchers, who update themselves, who evolve through empirical evidences, and who incorporate that in their treatment plans in a very proper way. So right is not about mental health right, it's about how to properly execute it. Thank you. And I hope that if anybody has some doubts, we can get back to me.
Thank you. Thank you, Gayatri. I haven't introduced myself. I thought it's a multidisciplinary team. I have been trained as a psychiatric social worker. I did my MPhil in psychiatric social work from Central Institute of Psychiatry, and I have done my PhD in mental health social work from the Monash University in Melbourne. I have practiced in India after my clinical qualifications, and then I migrated to Australia 16 years ago. I have been practicing predominantly in child safety and child's mental health. So, like Dr. Samir Basio said before, so mental health, when we talk about mental health, it is not the mental disorders that are clinically researched and has become part of the diagnostic criteria by WHO. There are many mental health issues that doesn't come under that purview. So a lot of the people have questions about mental health. I have seen one question coming through about there is a lot of stresses in life. how do we deal with the life is full of challenges, and how we can overcome those challenges. And as I said in the beginning, that mental health issues doesn't need to be, fulfilling a diagnostic criteria. So there can be mental health issues that can be addressed through non-medical way, or the way we talked about biopsychosocial model. So in a biopsychosocial model, or in a multidisciplinary approach, me as a mental health psychiatrist or social worker, so what we look at is working with the families, the family background, bringing up, right from the conception, like Dr. Sonia has talked about, even the prenatal, perinatal, postnatal, and anything that impacts on the parents, especially the mother during pregnancy, that has got an impact on the brain development. So when I have been working in child protection space, in the child safety, we have been talking about the development of brain. The first 6 years is the brain development. I'm sure Dr. Samya Basu will elaborate a bit more on that. Dr. Samya Basu is specializing actually about the neurobiology of brain and how it impacts on the children. Um, so that's very particularly about trauma. So when we talk about mental health issues, trauma has got a huge um, impact on people, especially children who go through traumatic events like family violence. So I have been working predominantly in the child protection area, where a significant population are impacted by family violence, um, and which has an impact on the brain development. Dr. Bruce Perry, who is the pioneer about the impact of trauma on brain, even the physical development of the brain, he's a living legend. He's an American neuropsychiatrist, and he talks about neuroplasticity. I'm sure my colleagues would be elaborating a bit more about the neuroplasticity, and also about the recovery model of practice. In olden days, or when 20, 25 years ago, when we were trained, we used to talk about the word rehabilitation. We no longer use that word rehabilitation these days. We talk about recovery oriented model of practice. So recovery oriented model of practice has got two components: the symptom recovery and personal recovery. So the symptom recovery, we need medications. For some people impacted by mental health disorders, they need medications. Some patients would require even electroconvulsive therapy. So it depends on the situation. But actually it is a combination. So medicines, the psychosocial connections, the psychotherapies. We talk about these, about the yoga, meditations, mindfulness, anything that can contribute or complement the interventions in mental health. So my area of focus has been actually, how to improve the functioning of families, because we have been dealing with children from dysfunctional families. So what does dysfunction means? So if there is no compatibility in the parents relationships, that has an impact in the role modeling, and on the brain development. So I often use this analogy of building a house. The first 6 years brain development is like the foundation of the house, and then 6 to 12 years is like the walls, and 12 to 18, the third stage, is actually the roof of the house. So if you don't do each step one by one, and that's how a person's personality or the life is developed. So when we talk about mental disorders or mental illness, there is something called predisposition and vulnerability. So predisposition is actually more of genetic, and vulnerability is more environmental, which I talked about trauma. We talk about trauma informed care. So trauma informed care is very important when we adopt interventions in mental health. So this is broadly about how we deal with mental illnesses and mental health issues. We have to differentiate that. I think these days, especially in Australia, we talk more about mental health issues and not diagnosing. We are not labeling people. And that is what will go a long way in destigmatizing and seeking help when people suffer from mental health issues. So this has been a big issue for people, and that's why usually people go for traditional healers and traditional practitioners. And so I always talk about, go to a clinically trained mental health professional if you have any issues in life. And we don't have that help-seeking behavior. In the Western world, it has developed quite a bit, that help seeking because any issues a person has, they go to a general practitioner and then get further referrals. A general practitioner can usually identify mental health issues and they refer to the specialist. Whereas in Eastern countries like India, we still have a lot of stigma. We still don't seek help from professionals. Rather, they go to the traditional healers, which, and by the time they reach the clinical setup, uh, it would have become worse. So we always encourage seeking help early in early stages. So this is what broadly I would like to say, as member of a multidisciplinary team, being a psychiatric social worker or a family practitioner. Um, I would go back to Dr. Shabir. Dr. Shabir, are you there still?
Yes.
Yep. Would you like to add more regarding how um, we go about how we can ensure mental health for all?
Yeah. I mean, it was very nice to listen to all the panelists. I mean, obviously, I know most of you very well, and you're very erudite scholars, and Soumya Basu has a very particularly powerful way of looking at clinical situations, and I've always admired that quality he has. The key issue here is not to do as much, as you said, with just having a diagnosis. There's a lot more that comes with it. And it was very interesting to hear this statement about how we need clinicians to be capable of delivering what they're supposed to deliver. I really like that because it is true. You can come to a doctor who really is not well trained in a specific area of work and expect to get better, and you won't. So, just as much as we are talking about the right to mental health, we are also talking about the rights of patients to effective mental health interventions. And that's extremely important. We don't often talk about it. So, how do we gauge whether a clinician is actually capable of delivering that level of care? Now, the point is, we don't. I mean, even if you go see a surgeon, sometimes it varies. Some surgeons are brilliant at what they do, some are good, they're not bad. But the point is, they all have to go through a certain process by which they are credentialed or they get a degree. We need to look at ways in which we can ensure that when patients go to get good health care, mental health care, the people delivering the care are competent. That requires very good training centers. And Soumya very nicely touched upon it again when he said, we don't have as many centers. It's not meant to undermine a system that is evolving. Far from it. It's only meant to highlight the deficiency in the system. So if for example, Sonia has won the awards and she's a popular female physician, it is because of what she brings to the table above and beyond purely prescribing. It's your approach to a patient, your knowledge base, the fact that you have treated people effectively. All these things come into play. So when you look at psychological templates, multidisciplinary teams, we have just as much of a responsibility to provide that level of care. Now, how do we ensure? So it's a very tricky thing because neither you nor I have the power, the finances, or the ability to ensure mental health care. All we can do is provide a platform like you have done, Josie, to raise awareness,
to give a safe space, quote unquote, where you can come and you can talk about it, you can address issues, you can raise your queries, and you know that we will try and answer it the best we can. In terms of what happens after that as a follow up, this platform cannot provide that, but it
So,
We lost
Josie, to
connection.
add on to what where Shabir is left, since we've
Yep.
lost network with him,
Looks like, yeah.
I'll just give you a very practical example to sum up what Josie, Soumya, Gayatri, and you were trying to point out. A very simple case example. I'll give you a case study. A young lady comes, first time pregnant, and she's in the village. Her husband is an alcoholic. She's a victim of domestic violence, and the mother-in-law accepts domestic violence as a way of life. And this lady has a past history of depression previously because she had suffered from a lot of trauma. She was a victim of sexual abuse in her childhood, and then when she gets pregnant for the first time, continues to face domestic violence, and she finds herself suicidal, not eating, not sleeping for past month or so. Her functionality has come down. She's supposed to be going to the fields in the farms to be working, and she's not working. And when she's brought by the local village Mitanin to us, whom we regularly interact with, saying this lady is not sleeping, not eating, she's not gaining weight, the obstetrician has pointed out. She's anemic, and the obstetrician has prescribed some medication, yet she's not gaining weight. So, in this case study, the red flags would be a past history of trauma, a past history of depression, a loading of depression in the mother also, that is genetic tendencies there, and she's in a psychosocial scenario where the husband is an alcoholic, comes and beats her up, and her mother-in-law is not supportive. And being a primey, she's all the time worrying that the husband is not earning enough, all the money is going in alcohol, I don't want this pregnancy. And she goes into clinical depression of such a severity that she's suicidal. So how does the team work? We had a Mitanin who early identified that this lady is not gaining weight, the obstetrician who diagnosed anemia, and the medical officer was trained enough to refer to a psychiatrist that this lady is suicidal. So the health worker has come into the scene. The social worker comes into the team to address the domestic violence. The psychologist comes to give interpersonal therapy to address these issues. And the psychiatrist to intervene if the severity of depression is so high, whether she would require even medication along with the therapy. So that's how a multimodal team works. Now, we don't have a trained psychologist trained for interpersonal therapy, but we do have a sensitive health worker, a sensible obstetrician, and we do have our team of psychiatrists who can be referred to. With this telemedicine thing, a lot of after COVID, we have learned so many things. We are connecting in a virtual world much more easily. So these teams can be formed. It's no longer that difficult. And in developing countries where the resources are poor, let me tell you, we work with a lot of passion. Our IS team has got a hold of list of 10, 15 psychologists in our program who give free services. They do have psychiatrists who are passionate, who give free services once a week. We have our medical colleges providing telecounseling and telemedicine now. So things are becoming easier to interconnect. And you have given a very good example to us that, we were from the same institute, but we meet after a long time and we're able to connect and share thoughts. So this stepped up care, this multimodal care can be provided, and we should be positive about it. And
May I
once
just
we interact with government also, because once the policy makers are aware what is the impact of these illnesses, a mother can become suicidal, a baby can be born low birth weight, and they are made aware, they will go out of the way to help you. And I think we have a senior policy maker who's supposed to be joining us today. Josie was telling he's very, very passionate about his work. And so I think Josie's imagination of the team was perfect. And Gayatri, you wanted to say something?
Okay, I may just want to add in the same line which you people were adding. I got a client in the previous week. I do online consultation. So she told me that she met a psychologist and emphasized in clinical psychologist. And she told she took 3 sessions and she told me that she has some concerns and all. She told me my psychologist told and she was sharing it. Then I got that she was having severe depression. She has self-harming thoughts, etc. So I suggested in the first session itself, psychoeducated her, and I suggested about medicine, and I gave an psychoeducation about medicine. She told that my past clinical psychologist, she met the clinical psychologist 2-3 days back, 4-5 days back, told me, I don't need medicine. No need for medicine. So, that client has better rapport with that clinical psychologist. And for her, I'm like just a newbie person whom she had to move on to because the other psychologists have no time, apparently. So I have to, it took me 2 sessions to tell my client that, see, I am a clinical psychologist. I'm licensed by RCI, and I'm doing my PhD. But let me tell you, in no point of my education, I have been trained to tell a person that you don't need a medication, because I don't have an MBBS, I don't have a PG in psychiatry. See, this is a very simple thing where, a person who has been trained doesn't know that, that ethics, or they don't know or they have the audacity to tell a person that you don't need a medication. So then I have actually, so later my client understood that, okay, I am not a daughter of some, or I don't have any dubious intention of, referring and getting money or something. So because that is not a point, right? Because they don't seen this multidisciplinary approach. So later she actually, she told that, oh, I really thought that you would suggest somebody whom you know or something. I would definitely, but you can find out a really good psychiatrist working in government setup or private setup, whomsoever have an education, has a PG. So this, I'm not just talking about, this comes from a clinical psychologist. At the same time, I have seen that, I'm so happy to hear what you people were saying about people from other departments are referring clients to psychiatry. I get some references where non-psychiatry medicos tell them that they don't need medication, and, just counseling, thoda bahut baat kar lijiye. And they would have already, yeah, they would have all, yeah, they would have already told the client also, like as if like, okay, medicine ka kuch side effects and all hoga, so you don't do that. Then I have to have to say that, okay, yeah, side effects, because we know side effects, and you are the person who do pharmacotherapy for you, he's a person who has special training 3 years at least in psychiatry. See, all these things is, sometimes I really wonder why a person who has, years of training in clinical psychology, or who are medicos, they kind of have that feeling like, okay, I don't have at least that, self-awareness to know that, okay, see, I don't have any education to tell a person that you don't need medicine. I think that
medical
is
model, no, Gayatri. The medical model of the illness has to be explained in a very simple manner to the patient.
yes.
I usually quote, say somebody has typhoid. You say you need a specific antibiotic for typhoid. You can't treat typhoid just by a diet, no? You need to treat it with a medical. That's how you can explain. You have diabetes.
Yeah,
So you have to,
I give the example of thyroid medication. I tell them that, okay, so we don't associate, because then I tell them that because we don't have social stigma associated to it. Some people take medicines for, because they have diabetes condition. So likewise, so I kind of do that, but sometimes, it scares me thinking that how many people may not just access psychotherapy and pharmaco treatments just because of somebody had told that no. So now it is not just we have to step up and psychoeducate people who goes for faith healers, jatput. We have to actually, talk to our fellow practitioners as well.
I think,
yeah, you're very right.
I think, Gayatri, the issues we have in the provision or implementation of the act is some of them are systemic. So we have a robust 2017 Mental Health Care Act. I remember when I attended the ANSIPS in CIP in 2018, and there was a plenary about the Mental Care Care Act 2017. And I found, and Samay would agree with me, it is pretty much similar to the Victorian Mental Health Act, the previous Mental Health Act 2014. We have a 2023 Act now. In a gap of how many years? I mean, we had a Royal Commission and then it has been updated now. But that 2014 Act and 2017 Indian Act was pretty similar. And there are clear provisions in it. And the other thing, so there are some systems.
Is Josie's thing working or
I
not?
think we can't hear Josie.
Model. So what we do in India is still a medical model. We can do that, and there are provisions in it. Everybody. So when we talk about mental health for all it is a universal human right. It is very much enshrined in this Mental Health Care Act. Even the human in our Indian Constitution, I think the section 18 of the Mental Health Care Act, it talks about every citizen should have the access to mental health. So there are provisions there. It is about the implementation. I know it is not easy. It takes time. I think there needs to be a cultural shift. There needs to be a systemic change, and that's why I have invited Prashant to join. He's still trying to join, and there is some technical issues. It looks like he would be joining any time from now because he was actually involved in Kerala with the mental health system, especially when he was working with the mental hospital in Calicut. And so probably when he joins, he would be able to talk about it. So there needs to be administrative reforms. There needs to be a political will. There needs to be funding. How much funding is very meager. If you look at the funding allocated to health and especially mental health. So I think that's where the issue is. And then we are presented with even major mental illness. I think Soumya will agree with me and Shabir would agree. When we practiced in India and then we were working in Australia and other Western countries, is we are overburdened with only major mental illness. Even for dealing with that, we don't have enough resources. Then how do we do the case management? But we can do it because there are plenty of psychologists and social workers available, because for example, in Australia, the case managers are psychologists, social workers, occupational therapists, and nurses. So once they are a patient is discharged, their care is continued in the community. So they take care of their whole life. So that is what we talk about, the holistic approach. So the role clarity needs to be very clear. And I think that requires a lot of education. I think that should start from the specialist psychiatry training institutes. We have Central Institute of Psychiatry where we have been trained, and then we have NIMHANS, and there are many institutions now who are providing training in that. But we need more, because considering India such a huge country, we need many training institutes where we train more professionals, and then so it is a combination of all that.
Josie,
Yeah.
there was a question in the chat box by AJ. Did we answer that? He's asking, saying life is full of challenges. How can we overcome?
Yes, I have been. I have put that question in the beginning. If anyone wants to answer, Soumya, do you want to add to what we have discussed so far?
Look, I mean, it's a wonderful discussion, but the point that Gayatri is making is a very important one, especially in Indian context. Um, you know, I can tell you one thing, Gayatri, is the total number of the population of Australia is like uh, any city in India. Say Bombay or Calcutta has the same population of all of Australia. In my hospital where I work, there are 120 psychiatrists. There are 21 child psychiatrists. In just one hospital. There are six or ten such hospitals in the city of Melbourne. The child psychiatry team is more than 300 people. 60 clinical psychologists, and still with that number, we are struggling. When the mental health, so when the awareness is there, and here in the Western world there is hyper awareness. The awareness is from school onwards. We have got a minister of mental health. So there is a ministry of health, and there is a ministry of mental health. We have royal commissions on trauma, royal commission on sexual abuse, royal commission on intellectual disability. So there is a hyper aware society where everyone knows about mental illness. So from there to India, where the total number of psychologists that we have in Australia is more than that in India, and still here we are struggling. So how can we? And the 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 fallacy is at this moment as we are talking, I've got a professor, the ex-professor from Sri Lanka, who is just visiting me. He has trained in Oxford. He has again trained in Montreal, in McGill University, and he has worked for a long time in Australia. However, when his child psychiatry training he has had in Nimhans, and he said among all the institutes that he has ever been to, I mean, he has, in England, he also trained in Maudsley. So all the training institutes that he has been to, and all the conferences that he goes to, the Indian psychiatry is next to nothing. That Nimhans, the training that he got in Nimhans is better than anywhere in the world. So here we have centers of excellence, which is as good, if not better, or the best in the world. And but then there is nothing, and the number of patients that you're not even seeing is something staggering. And how do we, provide? And we do not. I mean, actually, we do not. From Indian perspective, we do not need to see westwards. I mean, and this doctor was saying that the best conference that he attends is the ANSIPS, which is a bit of an exaggeration, I think. But anyway, he was trying to. But he says that all these conferences is people from all over the world come and contribute back to the society. So how can we use the Indian diaspora? I mean, there are more Indian psychiatrists who are practicing abroad than practicing in India. How can we use the diaspora in training the local, or learn from each other? I mean, we run a child psychiatry training program in India from Coimbatore for the last 6 years. We have trained more than 500 people not 500, it will be nearly 300 people in the last so many years. So, and the quality of the trainees is so significant, and we work with clinicians here on a regular basis, and then I have trained with social workers and clinical psychologists in CIP. Sometimes I really feel that the center of excellence of India, are they overdoing it, and do we need a second layer of training and supervision, ongoing supervision, where we can provide care en masse? In the field of infant psychiatry, where the Sonia's case example is quite jarring, mental illness in the Western perspective in that setting is much more subtle. I mean, I'm working in an inpatient setup where they provide. I mean, it's a private health setup. So most of the cases that I've been trained in managing borderline personality disorder when they are becoming mothers. But now I'm seeing the grandmothers who had borderline personality disorder. The mothers are having, at one point of time, I had about 4 patients. All of them were more qualified than me. 4 PhDs, highly qualified obsessive mothers who've gone given birth to a child and do not know how to manage this and cannot go and get the help from the mothers because the mothers have even more severe mental illness and personality problems. So we have got a massive divide between the global north versus the global south, but somewhere India has got that absolute center of excellence, the best in the world, and how can we tap to those resources? And just demands will not make India. We need 10 such demands all across the country, and it needs the political will and a great awareness because this is very important. You were talking about childhood trauma, and life is full of challenges, and how can we overcome? So this is very important. What you have just mentioned, the impact of early brain growth, neuroplasticity, and trauma. So there is a groundbreaking study that has happened in US. It's called the Adverse Childhood Event Study, and that has been replicated in Australia, and it's called Childhood Maltreatment Study. The adverse childhood event studies show that when the children are experiencing early childhood trauma, and that is again the work of Bruce Perry, from perinatal period to the first 3 years of life, the brain is totally hardwired by the first. So we call it 1,000 days, the first 1,000 days. There was and there is such a great awareness in India even about the first 1,000 days. And it is quite evident that the impact of early childhood trauma, which includes sexual abuse, physical abuse, emotional neglect, exposure to domestic violence, parental death, parental separation, parental mental illness, parental substance use, parental incarceration. So, as you can see, childhood trauma, most of the things are to do with the family and the parents. So, it's such a powerful model to show how the environmental factors can have a major impact. So, more the childhood events in adult psychiatry, in adult life, it not only mental illness but even physical illness, early death, cancer, uh, everything is highly associated with increase of um, early childhood adversaries. So it is not that what we are preventing is mental health, but the whole of health uh, has a big impact on the interaction between mental illness, mental illness, parental substance use, and not only psychiatry but whole of medicine. And the economic impact of that is staggering, and that needs to be really understood by the key stakeholders and the fund providers. And in the developing world, the role of, it's just the opposite. In India, it was embarrassing to be a psychiatrist. Here, it is almost a privilege. Everywhere, it gives the highest priority around mental illness. Sometimes I feel that it is too much, but uh, you know, the profile of mental health in India, hopefully is getting better. I have to admit, I'm a great. Sonia is my very, very close colleague. The leadership that she has shown in the field of infant mental health, just within last few years, she has started with a group of people and she's turned it around into a very important discipline. And the key things that she said, women, women IS officers, those who have gone through this experience, to include them into the fray. It's just It is fascinating to see how the psychiatry is changing with the introduction of women coming into the field, and how it has really brought out some of the most nuanced challenges that we have been facing for such a long time, and which has always been there, but it has not been spoken about. The impact of domestic violence, the key cornerstone of mental illness, which is intergenerationally transmitted. So the work on that we need to be aware of that, and we need to understand, about how we can work on that. So, over to you, Josie.
Yeah, adding on to that, I was, I have been talking for some few years about raising awareness about mental health and, you know, child safety, women's safety, stopping violence against women and children. This is very common. This has been normalized, not only in India, all across the world. Even in Australia, we are grappling with growing um, family violence and the impact on the victims, and especially the women and children. And these are the children who are traumatized and later develop um, various mental health issues. In India, it can be done. It is a growing country. There are a lot of infrastructure that, like Soumya said, we are highly trained in psychiatry. I mean, if you look at Australia and other Western world, they are not highly specialized training provided in mental health. They learn it on the job. I mean,
On
we
the
have
job.
so many people with a master's in psychology and master's in social work. They can be trained. The doctors, physicians can be trained, and they can, like GPs, do the basic, a lot of basic diagnoses. And so it is about getting help. When I did the session on 10th of October in the regional language in Malayalam, because Kerala is one of the states, the progressive states in the country where education and health is of Western standards. And I have been advocating about, Kerala becoming a model and doing it, because there are various ways of doing it. We know right from the three-tier level of, the local government, from panchayat to block to district to the state. So if we have, professional psychologists and social workers trained and appointed from that different levels, and then reach those who are, they're called, I always use the word gatekeepers, picking up early warning signs. Every suicide is preventable. So if we reach people help and reach them to the specialist, so a lot of work can be done behind, but again, there needs to be a lot of funding required. There is a political will, funding needed, systematically done. It is doable. There are thousands of masters holders in psychology and social work in Kerala, for example, in the state of Kerala. And that, if that becomes a successful model, because Kerala has done it in education and health and shown, and other states are emulating it. So if there is a successful model in all these aspects of specialty of mental health interventions, that can.
Josie, we have one more. There is one more issue that comes up, and Gayatri brought that initially when she spoke about how we have to deal with people who are more soothsayers and motivation speakers than actually interventionists.
Yes.
So this is another layer of problems that come in, because you can start fixing a broken bone, but if you don't fix to deal with the consequences of that, it's the same thing with psychotherapy. If you don't have somebody who knows what to do, you end up creating more of a problem downstream. So we need to keep that in mind as well. Thank you.
Yeah, I mean, obviously that. Yeah.
I just wanted to add the same point where, everybody here was, when we were talking, we are not just seeing it individual. We are actually seeing one. Soumya Basu was talking about how the grandmother's personality disorders and their trauma, that is the intergenerational trauma concept, it's right there. We talk about systemic issues, we talk about geriatric, how everything is interconnected. We know this because we have been trained in a place where multidisciplinary approach is possible right now. And as Dr. Basu said, here we have one of the topmost training institutes, but what I feel is that they are just the government or the policy makers are not efficient enough to connect the public health with mental health. When I told somebody recently that once I finish my PhD and I'm doing it in trauma, my focus is trauma focused therapy. So I told after this I want to do a PG in public health. People are like, what is the need? Why are you doing it in public health? Because how many policymakers are connected and how to efficiently use our resources. Yes, we are an overpopulated, we live in an overpopulated geographical location, but how can we, one focus could be like how to effectively maximize this, how can we bring trainer of trainers programs here. I'm amused, I don't know you other people except than Josie. Up until this moment, we don't have, there are people who specializes and talk about infant psychiatry. I work in clinical psychology. I'm focusing in trauma. I'm focusing in trauma. Most of the I do online therapies, and I haven't heard about. I didn't got a privilege to know a person, a woman who's working in this area. Up until this moment, up until this program has been connected. So, that connectivity, that connection is not there. So whether it is any for efficiency, that interconnections is, very much, that is very important. And, we have expats who have really good experience and insights about how India is. And they have seen foreign lands where they know how things go on in at least 2-3 continents. But where are we failing to use these intellectual capital, I must say, this knowledge capital, which at least the four of in this stream, at least that 4 other people are talking, these intellectual capital and the knowledge capital which you all are having, the system is not efficiently channelizing it.
Yes, and that's the purpose I have been
Actually,
doing this for the last few years, because I would like to, because I have seen working in India and I have worked here and see the difference, and I have to, we would like to contribute, and that's what Samir Basu and Shabir and I, we have been talking about it for some time now. We would like to give it back to the country, and it is not on any remuneration. We are taking our extra time and efforts, like we are doing it now. This is already midnight past, it's 1 o'clock now. In Australia for Soumya and me, and this is what we are trying to do. We would like to give that feedback. We would like to provide advice and consultations for this implementation, and it is a work in progress. And I have been doing it for the last few years, and I will continue to do it. And that's the purpose of this all about.
It's not a failing, though. Yeah, Gayatri, it's not a failing. Don't feel bad about it. See, the thing is, where did we start? We started off with just a few institutes. And with just those 3 institutes, we have amazing training. We are not really failing. The only thing is we need to make sure that we actually don't fail as the years go by. We have to be able to generate human capital management, make use of what we have, leverage the resources. The very fact that you're asking those questions is actually part of the solution.
No, I was actually sorry that I used that I put it in that way, but I was actually thank you for, I stand corrected. It's like it would be more effective way to put, like, how can we win better? How can we positively use our resources in a more efficient way?
And if you
Yep.
see the WHO, no,
You need
when
to
they
pull
first
Sonia.
talked about mental health, I mean, initially what to say, maternal health is the most essential part of good health. But people started making them realize it's maternal mental health, because it directly leads what Soumya pointed out, the concept of fetal programming. So you need to educate. We need to bring awareness even in our policymakers. We needed to talk to judiciary also regarding what is the
Yes.
impact of a mental illness. You see, they're not educated on that. So
Yes.
yes, we have to make bigger platforms to reach out, and we cannot be sitting in our ivory towers. We have to reach out. So when it comes to school education program, when it comes to educating teachers, it
Abs-
comes, we have to reach to the grassroots level. I always say, when Soumya's telling, somebody told me, calls me perinatal psychiatrist. I said, no, I'm an adult psychiatrist who is seeing patients of perinatal area as well. So in CIP, we were trained to identify a whole spectrum of disorders. I think nowhere in the world other than CIP, NIMHANS and other some major, where you have this multidisciplinary work, but you can replicate it. You can
it is
always replicate it wherever
unreplicatable.
you're going. You
The
can do that
training that
work.
we had, I don't know whether there is any model anywhere in the world.
I
To
agree.
be
I agree. You're
to be
absolutely right.
working with people. I mean, so Sonia, you remember when we started, our colleagues in psychiatry, in psychology, and social work, they had 5 years of experience in mental health. The psychiatric social workers, the level that they were talking at, we did not even know. I never heard about Foucault. They were talking about psychiatry, anti-psychiatry. They were talking about stuff that we did not even know, and the psychologists, they knew 100%. So the first thing that we learned was to forget being a doctor. That we are the champions of the world. We knew that biopsych most of the psychologists knew much more about everything more than us. Their knowledge on statistics was more than that. Their knowledge on research methodology was better than us. In psychopathology, I mean, Tilottama used to teach us psychopathology. So it gave us that grounding of humility, in the multidisciplinary aspect. And that biopsychosocial approach was ingrained within us totally right from the beginning. And in Australia, there is no training like this. The clinical psychologists don't talk to psychiatrists, the psychiatrists don't talk to, but in clinic they start working together.
I
And
think,
a
yeah,
lot
that's
of
very important. What you said, that the clinical psychologist was so trained that that person could understand that this patient requires this sort of therapy and this kind of medication as well.
Yes.
So, out here we have MA psychologists who are not trained about neurobiology or brain at all. So, I have a very difficult time working with the MA psychology, whom the government has, given a easy go. Okay, MA psychology, you have to have a psychologist in the institute. But I miss the team of clinical psychologists of the expertise of NIMHANS or CIP, specially trained in trauma focused therapy, specially trained in IPT, specially trained in CBT, and they are so intelligent that they could tell, yahan pe this patient requires ECT, this patient requires medication, you can't stop it. There was never any rivalry between our teams. We had such good understandings that our clinical psychologists would take a BT, behavior therapy, or an OCD along with our medication, never telling कि medicine बंद कर दो. That understanding was so good. So teaching even the biological aspects of the illness to the psychologist is so important. Gayatri's the point that she has raised, to deal with the ordinary motivational healer, soothsayer who's competing with the clinical psychologist. A clinical psychologist who work in a team of a psychiatrist is doing wonders. But we are lacking, Soumya, I must admit, that our training, compared to what training you have received in the West, we are not trained exclusively in infant psychiatry. We are not trained, even special. Our clinical psychologists are looking for experts to train them in PTSD therapy, what they're going to give in PTSD. We are lacking that. We know we do need more experts, and I think that's an area where the clinical team can intervene and teach both the psychiatrists and psychologists. But knowledge about pharmacotherapy has to go down even to the clinical psychologist. Only then, and that came very easily in our training programs in CIP, but doesn't come about everywhere. There are psychologists who are trained only in psychology, and they are the ones who will abruptly get the medication stopped. Your IS lobby, let me tell you, the first thing they'll say, even if their own child is not well, who's severely depressed, say, their own wife who's suicidal, they would want only therapy. They would not want medication. So unless you educate, you need to put
Exactly.
effort.
Here,
They sorry to they kind sorry, somebody else was talking. I'm sorry.
no. You go.
No, this is exactly they kind of advocate like they say that okay, no need for medicine, just therapy is enough. So actually they don't know that psychotherapy, medical complaints, increasing medical complaints is a part of it. So even though if you diagnose mild depression, it's not like you have to give them give them informed choices about, see, their pharmacology, these are the things they do. So I sometimes give these examples like, I got trained in CIP, so sometimes we get clients from Purulia or some areas where we need small examples from people who are predominantly farmers. So I tell them like, okay, see, it is like Belgadi. If you are like, if psychiatrist and psychologist, it means like it's a two bulls wala bullock cart, so that thoda tezi और होता है and efficiency और होता है. And with urban clients also, we can say that most of the research evidences suggest that combined effect of pharmacological treatment and psychotherapy, it's in all researches. It's across the Google Scholar, where any person can just look and Google Scholar, or anybody. Yeah, they might not have the privilege as we are having our institution access, but still they can just look into it and say that okay, acha, so this is the best way. So I think that extra steps can make this our system more efficient.
Good point.
Yep.
No, the psychopharmacology in children. I mean, I work with children, especially psychopharmacology in children is a very difficult. I mean, the skepticism in India may be due to lack of awareness, but with all access to all knowledge, there can be skeptics too. I mean, I remember the World Psychiatric Congress in Melbourne, and an entire street full of placards from Scientology saying WPA, how many children you have drugged today, and it's all over the world. Wherever there is a psychiatric conference, especially child psychiatric conference, there are people with placards saying that no medication, don't drug our children. So, and these people are super educated, not just uneducated. So, too much of education is also a problem, because then they will bring out all sorts of evidence and non-evidence, and come to say that how do you judge different? I mean, so it is sometimes wisdom and education don't go hand in hand, and I'm some of the smartest people I have ever encountered, especially while working in the field of autism and ADHD, are Indian, people in India, just the grandmother of a child who just had lots of experience and not so-called educated, but understands the human mind. So it's quite, I mean, the issue with medication in the Western world is also quite serious. So here they would say that the children are being antidepressant in children. It is seen as a lazy version of medicine. So if you're not having psychotherapy, you're giving medication easily. So it is much more. And here because it's a psychoanalytic model, child psychiatry, much more to do with psychodynamic thinking. Giving medication is often seen as a shortcut. So it's very interesting. We can come to the same conclusion due to lack of knowledge and over knowledge as well. So
Just to add on, I have a client from a certain European country, and that client actually, she was having severe depression. She's an Indian expat from India, so she somehow contacted me, and she just told that she told that her, in a very very well aware, their doctor to client ratio is very amazing. And she told that she went to see a psychologist, and that person heard everything. And that psychologist told two things. One thing is, okay, you do prayers, and they said meditation, and told that. So my client told that, okay, see, I'm not much into religious practices, and then said, okay, then you go to some. I'm actually paraphrasing, but I'm telling exactly what my client said. Not exactly, but paraphrasing. Said the previous psychologist said that you connect with nature. You just go and sit in the river banks or something. Okay. Now we may not see the problem of it. Actually, my client had severe depression with suicide ideations, and my client has a father who was a psychologist. So their trauma, there were history, abuse. Actually, her father was not a psychologist. He has a distant degree in psychology. So that kind of one who does conversion therapy. So there are a lot of, and somehow that woman got mustered up the courage to got a help. So that time, in certain European countries, it's not easy to get a date of a psychiatrist or a. So this psychologist, she was just saying that, okay, you now go and sit in the river. You connect with nature. In the first session, then it took me 2 sessions, but her medical complaints, I didn't have to work on medical complaints. I had some conversation assessments, and I told, you have severe depression. I'll give you reference letter, and I wrote it, and she tried in another non-English language, then gave, and the psychiatrist suddenly he gave medicine, and he told her to take, if it is possible, take a break from the lab which she is working. So she's like, and then you see that the way she was thriving, and that was some kind of my cultural shock, when I thought that, okay, so this happens in Europe, oh okay, this happens in UK also. But I was able to connect that, okay, even it's not about hyper awareness. Sometimes that concept of, if we talk about, okay, Josie could connect when we talk about systemic issues. I don't know how many clinical psychologists uh, address, or how many mental health experts address systemic issues.
I mean, there are some isolated cases like that, but generally there is a system here, and I do hear what you are saying, and I myself see that outside my work, because a lot of people from Indian origin approach me and talk about, and I always direct them to use the system, because we have a GP system, and that is what they need to be doing, and GP would do the appropriate referrals. Of course, there are waiting periods here because there is the resource issues here. That going to the nature and doing yoga and meditation, I mean, they are part of, but I'm not sure about how that happens. Sometimes people of Indian origin have that, still bring that stigma back, and then they don't have that help seeking behavior. But
Yeah.
generally, there is a system here. People seek help. It's a cultural issue as well, which is again there in India. Shabir, you were going to say something before? Shabir, can you hear? Okay. Yeah. Soumya, you are there?
Yes,
Right.
I'm there. I'm there.
Right. Do you want to add on to that?
Look, you know, the I mean, psychiatry is much more similar, in training all across the world. And I had the privilege of working and having, you know, 2 degrees, 2 degrees from India and two from here, and a full training from here as well as in India. With psychology, anything it's a very 100 different sort of therapies, past life regression therapy to cognitive behavior therapy, mindfulness, mentalization, trauma focus. With the types of the variety of different types of therapies and the evidence base and lack of evidence base, and and what is real life versus what is non-real life, because real life patients are not even in research, so it's quite a um, challenging field, and the neurobiological basis of exactly how psychotherapy works will be very interesting to really ascertain, the human factor in psychotherapy, the role of the therapist, the therapeutic presence. It's a complicated area about psychotherapy, however, in the range of types of psychotherapies that we have here is staggering. And one of the important things that is now changing everything is the role of mindfulness meditation in psychotherapy, which is becoming a most important part of research. And during our entire training in India, that 10, 20 years ago, there was no mention about mindfulness meditation in psychotherapy. So, with Deepak Chopra, what he has unleashed to the world is about $1 trillion business. And sometimes I believe that it is how those mindfulness practices are commercialized in a Western setup. Um, I mean, I think the point is there are lots of resources within India that we don't know. I mean, uh, right, for many years there has been studies about pros and prognosis of schizophrenia, which is better in the West, in the developing countries. The There are lots of X factors in the developing world. I mean, here we have got adolescent patients. We put them in a unit, and the parents sometimes struggle to come and just visit them. In India, the parents would take leave and stay with the children during therapy in CIP. I remember, and in the cottages. That sort of a cottage model of therapy is not even there uh, in Australia. Sometimes I had patients where uncles and aunties would take leave and come and stay. So the community feeling, the interconnectedness, the impact of that, whether it has to be research from a Western model or we have to develop indigenous models of research is very important. I mean, India is one of the biggest economies in the country. We have a massive diaspora where we are doing remarkably well all around. However, the colonial mindset, we are much more colonized now than we before freedom. And hopefully, we have to really, the indigenous researchers will have to find out what are the factors in India which is keeping it going, because the numbers do not match. If the numbers that we have in Australia is replicated in India, you will never have enough psychiatrists, psychologists combined, to look after that population. There is definitely some major psychosocial factors that is helping India not children not to go into a major mental health crisis and having huge amount of suicide and stuff like that. And those factors have to be understood by Indian researchers, not following the Western model, but the model of care from Indian perspective. That's what I think.
Yeah, I mean, Soumya, you would remember when we started here, we would see maybe 20-25% of the population that are presented in the mental health system have got major mental illnesses. 75%, I think three-fourths of them are more trauma based. And that's where, we started talking about mindfulness. And when I was looking at, I haven't heard about mindfulness before, but I know yoga and meditation because in my graduation was in philosophy. I did 6 months yoga course, and I know all the asanas and pranayamas, and I used to practice earlier. And I have also done meditation as well. And then when I looked at the mindfulness, it is a combination of yoga and meditation, but it is not really yoga or really meditation. So, and it has been said, but something is better than nothing. I mean, even mindfulness is also getting, if you look at the neuroplasticity. So when people do coping mechanism, healthy coping mechanism, there is neuroplasticity. It's all proven now, and we know that. And I myself have experience about that in my own life, and I had a trauma, and how neuroplasticity helps when you have insight. So, it's a very, like Soumya said, we in India are still, even after 25 years, still very medical, still very much dealing with the major mental illnesses. We have vast majority of 1%. If you talk about incident prevalence of schizophrenia, means it's 1.4 crores. So and then look at the other psychosis, bipolar and others. Where are the resources there? So who are dealing with the trauma, people with a trauma background? They just suffer, right? Lots of suicide. So there's going to be, like Soumya rightly said, it's going to be huge issue for suicides and other illnesses will have an impact. And the post-COVID, what is happening around the world, and the human rights violations, they all have an impact. What's happening in the Palestinian Syrian conflict, or any conflicts that happen in the world, everything has got an impact on the people. So it is a crisis time, and I think it's very important that the administrators, the politicians wake up and aware about it and allocate funds. There are trained people. When we were trained 25 years, there were only 2 institutes, the CIP and NIMHANS. Now I hear there are 19 institutions that provide, of course, I'm not talking about psychiatry. There have been, medical college psychiatry department, 4 seats or 2 seats MD. I'm talking about clinical psychology and psychiatric social and nurse. There are 19 institutions now. Gayatri would agree with me. So there are more, but 19 is nothing in a 1.4 billion strong country. We need thousands and thousands of institutions.
But the thing, Jyoti, is we always have to start somewhere. So 19 is better than 2.
Yes.
Right. And even if we do have a larger number of services, so for example, if you have the Australian model, the point is mental illnesses are evolving. So there is no way we can actually be completely prepared for what eventuality will hit us. The issue, though, is we should have some degree of resilience within the system. So if you have somebody who is working in Chhattisgarh and she's focused on perinatal and she has access to somebody in Australia like Soumya Basu, that becomes a source of knowledge transfer. Number 2, if Gayatri is there and she's saying, I'm having difficulties with this, I'm struggling to navigate this, and then there's somebody who can actually be a mentor or a guide, you're bridging that gap. With AI coming in, many of these things are going to be actually in many ways tackled in a completely different fashion. So what we should do, I'm always a very hopeful person. I believe there's no point in feeling hopeless and pessimistic. It doesn't help anybody. It doesn't help people around you. But being hopeful does a number of things. One is it brings people together because we all live in hope. There's always going to be things that happen around the world that we really don't have control over. And there's always going to be politics. But then you have goodwill. You have wise people. You have intelligent people. Not everybody is wise, like Soumya said. But the point is we leverage the people who are like-minded, like you've done today. So I actually am quite hopeful. I actually see good things happening, and people like you bring and create that platform where it can happen.
Yeah, absolutely. Gayatri would agree with me. We have been doing a lot of clubhouse talks, and I have done about 15 consecutive Sundays. I have done talks related to mental health, and there have been so many people regularly attending, and I get a lot of messages and phone calls seeking help. And we had a group of about 150 psychiatric social workers, with MSW and MPhil minimum. 150 across all 14 districts. And I asked where this particular reference come from. And I asked the group, can you see this person? That is what I have been doing in the last 2-3 years, all 14 districts. So we have a network. And that's what I thought, that's a good model we can, implement and emulate. There are so many resources available, and that's why I wanted the administrators to be part of it. Prashant is unable to join. He's saying he's very busy with the political commitments. He's a special secretary to the government, and dealing with the chief minister and the minister. So I have been regularly communicating now. Somehow, unfortunately, it would have been really good. He's very passionate. He has written 2 books actually about mental health in Malayalam. So I have him, and there are some young IAS officials in both men and women in Kerala. I think it's true across India. I think this is a model, Soumya and Sonia, I'm talking about. That can be emulated across the country. It's not just one state. It can be done
Josie,
everywhere. But
Josie, when you get Prashant ever on board, I don't know if Shabir and Soumya, you both are in the West now. In India, there was a very senior professor of ours who had once had a theme of an ANSIPS, how to retain Indian family system for improved mental health results. He was so passionate that how we can retain, because you see the DOSMET study, the result on schizophrenia, India, Nepal, Pakistan, Bangladesh, similar culture, we had better results, even though we didn't have access to great expert psychiatrists compared to US or Russia, but we had better results. So policymakers, how much they are contributing to breakage of family system these days. Husband posted in one location, wife in another. It's distance marriages. The parents are not getting time enough for their kids. Even in government sector, the workers are working 12, 14 hours. It is no longer that cozy government job where people are working 6 to 8 hours. You have the luxury in the West of having a 5-day week. In India, we are grassroots level workers, whether private doctor or government doctor, all are working 12, 14 hours. And everybody is stressed out. Everybody is surviving for basic things like enough money you need to have a decent home. The economy and the job lack of, what should I say, autonomy, financial autonomy is making people work harder and harder, and that is showing its impact in the Indian families tremendously. You have mobile addiction here, you have substance abuse on the rise, you are having similar, I know in Raipur itself, I can tell you, sudden change in the landscape of illnesses that we are seeing. There is so much rise of addictions now. There is so
It's
much,
here
I mean,
also. Here
yeah,
also,
so in India is
Sonia.
following the same Western pattern
Yeah.
now.
हाँ बिल्कुल यही पे हो
Policymakers have to think about it,
that
how
is
we can retain the family, how can we
that is
remain
correct.
interconnected. These are issues which social workers and psychologists, I think, should be highlighting. And
Yeah,
the medical
And
model,
very
again, I
important,
repeat,
very
yeah,
of
important,
course,
Suna. I mean,
yeah.
this is you have to lead this thinking. It cannot be a Western. So lot of look, in our lifetime, the entire West is looking India towards India
exactly.
for
Yeah,
for mindfulness and meditation. And
yeah.
I mean, Shabir is a master on that. Talking about mindfulness to big audiences. And here, one in my daughter's school, from prep, they teach zones of regulation. It's like dialectical behavior therapy. They teach it from school onwards. So they're from prep. They're teaching mindfulness. The key word is kindness today and compassion. It is not about competition. It is about how you relate to others. So the early intervention, preventative mental health. We have got school mental health programs, but one important thing that from an mental health perspective, and I've been involved in infant mental health for a long time. Uh, that field of infant mental health was laughed at by psychiatrists, let alone other professions. So they were totally laughed at, and now it is a most powerful sort of organization all across Australia. But we had to have that relentless pressure on politicians, symposium, education, talking about mental. So that was a model of how infant mental health 10 years ago in Australia versus 10 years ago. I mean, 10 years ago and now. It was such a big difference. How the Royal College has helped us. But I feel that the infant mental health is so important that uh, that the education that you provide to Anganwadi workers, around other basic physical health should be provided. And you know, though it sounds very specialist, but it is not. There is a hundreds of generations of knowledge, in India about raising children, in a family, and how that knowledge can be tapped into, through working with Anganwadi, and it is not just psychosis. It is just not psychosis. It is so many, I mean, variations of your case is a classic. It's very, very gross. The mother-in-law rejecting the husband coming drunk. She has got early exposure to sexual abuse trauma, and she's got pregnant. She doesn't know where this money will come from. She's being brutalized. So I mean, some of those uh, and here in the West, there is a big movement on lived experience. So all the psychiatric services, they have people who are the special. The specialist is the patient. So the patients are being employed in all the services for actually providing insightful learning for the clinicians, and that is a game changer, in many ways. So lived experience, people being employed, and so the infant mental health, which is the key, because the mother's mental illness will have an impact on the child's development, and that will start the all sorts of difficulties. I hope that the people can use that the Anganwadi model as a model of intervention, from the grassroots level, and that is surely possible.
The
I think
gatekeeper
that's a
I was
great
talking
idea.
about.
That's a great
Yeah.
idea, Soumya. We'll do some thinking on that. You've really made me think more on this. I
Sonia,
think
Sonia, that the
Sonia, sorry, Sonia gave me a platform to give a lecture on infant mental health, perinatal psychiatry. So instead of talking about mother's mental health, I talked about father's mental health. So, not a
Nice.
dyad model. I talked about the triad model, and I talked about the role of the father,
yes.
in mental illness, and for that Indian Infant Psychiatry Conference, I talked about, and in my work, that inpatient unit. So it's like you cannot imagine. It's like a 5-star, 6-star hotel. The all double bedded thing with a ante room for the babies, and the fathers have to come. The fathers have to come. The fathers have to do the programs as the mothers do, because it cannot be just the mother, and that perinatal is not mother baby. It is the
Right.
father, mother, and the baby. And when the fathers are not involved, it creates the pressure on the mother.
Yes,
Yeah,
yes.
Yeah. So
definitely. I totally agree
uh,
with you.
and the postnatal depression, it's completely, it's unheard of in India. I think it's not recognized at all. Whereas here,
Very.
yeah. So that's where the father's role come in. Fathers understanding that and supporting the mother and
You're not allowed to be depressed in India. Or at least all the focus is on the child only. How
yeah.
can a mother
That's
be like this? I don't know how many of you have read the recent controversy about Deepika Padukone. People
yes.
started raising Indian Psychiatric
Mm.
Society had taken her
Yeah.
as brand ambassador. And people
Yeah.
said, she has name, fame, she has all the facilities. How can she get depressed?
That's correct.
What will
Denial
keep her
mechanism
depressed?
is what we thrive on. We are like, okay, we just
India is,
deny, we
yeah.
use denial defense mechanism, and we are like,
Yes,
okay.
there's so much that you are doing different, Soumya, and we are at a very primitive stage. I must humbly
not
agree.
primitive. I mean, I
And
feel I mean, I feel I mean, Shabir. Look at Shabir and his career, and just and there are so many. We are all trained in India, and the training that we have got in India is second to none, absolutely second to none. And I mean, the load that you take, the amount of patients that you see, the battles that you fight, no one in the world can imagine, what you are doing there. And I feel, I mean, like Shabir, I'm absolutely very optimistic. Um, and But I think there is something, that X factor that we have, which makes India, Bangladesh, Pakistan have better psychosocial outcome, that X factor has to be really understood,
Yeah. Yeah.
from Indian academics, and
Exactly.
sort
I
of,
totally agree with you on that.
yeah.
That even child
And
rearing practices, the grandmother's knowledge in bringing up a child, the way she brought up a child, that knowledge bank of the Indian tradition, I sadly feel that we should not lose out. That bank has to be tapped and investigated and researched. Maybe
And the
we'll see some.
grandparents always bring out that tenderness and acceptance and that, pampering, all those things, that all those psychosocial factors which dad provides.
And you know what? When I
It is an
was
important.
the other area of work that I've done is in transcultural psychiatry. And Sabir and I, we are wanting to do a big symposium in India when in at NSIPS about Indian parenting in abroad and all this final nuances. And I was thinking of writing a paper on the grandparents effect. The migration, mental illness, the parental isolation. How is culture transmitted? How is a culture transmitted? I mean, suddenly, I mean, my both my wife and I, we are Indians. My daughter is fully an Aussie. I mean, I do not allow her to support the Australian cricket team. Apart from that, she is she is very much an Australian. Uh, I mean, but the lack of the grandparents. I mean, I make sure that my parents do FaceTime with her every day. And when she was a 3-year-old, 2-year-old, my mother would do almost a play therapy like on telehealth play therapy like interventions. That she would play around, and my mother will talk to her, and she speaks fluent Bengali. Fluent like. And the town that I was living in just had one more Indian family, and that person spoke in Tamil. So she, despite just that, the role of the grandparents is just not itself. It is regulation, it is empathy, it is flowing of culture, and that internal migration that Sonia is talking about. So, the internal migration is at the highest level. A Punjabi husband marries a South Indian, I mean, a Tamil person in being raised in Gujarat. So the house help is the person looking after the child, and the child doesn't know what language to speak in. So India in cross section, urbanization, all the challenges that you will be facing, but then there is that the human factor, the family factor, the interconnect. One thing that India has, this is very important. During the global financial crisis, there was global massive difficulties in all areas of finance, but the remittance pay, the people that send money home to family, that did not stop, that actually increased. So that compassion that with which people are born in so-called the global south is an X factor that needs to be tapped into. The interconnectedness, the meaning of me versus meta me, the expanded version of me. There are number of such factors that we need to understand from a collectivist point of view. The global research is dominated by the global north, and their problems are more severe than us. There's so much of problems that we cannot know. And how do we package and understand the Indian parenting or Indian living, and not lose it? Because if we lose it, the pandemic that is coming, India is not ready. I mean, the mental health budget has to increase 1,000 times, 5,000 times to meet that challenge.
Okay.
yep. Any
Josie,
final
can we
word
take leave?
from everyone? I know we wanted to do it for 1 hour. It's already 2 hours. This is what happened in my last session as well. We wanted 1 hour. It went to 2 hours. And mental health is a topic that is it's like an ocean. You have so many. I was going to say about that kindness, compassion, and all that you have covered. Thank you for that. And I was going to say about that. I think it's
You
more
are
about
telling me that you were telling me in the beginning, no, Soumya doesn't is coming quiet. You just triggered me, so I did not allow anyone to speak.
yes. Yes, you would remember we did that symposium about the FAPMI, families where a parent has a mental illness. So we are talking about children of parents with mental health issues. Do we ever think about that in India? Children. So it's an early intervention program. We did that
So
in the
remember what happened. Remember what happened during our talk.
Yep.
Remember what happened during our talk when we were giving that talk in CIP. Do you remember what happened?
Yes, you cried.
Why? Because one of the psychiatrists there got up and
Yes.
told his story.
Yes.
You know,
His father was schizophrenic. Yep.
his father had schizophrenia,
Yep.
and the story that he told us, totally shook us up. Totally.
Yep.
I mean, his child, the father was a IIT professor who had paranoid schizophrenia. About the whole life. They were terrified because they were thinking that the house is being micro, the microphones all around the house. Then the father lost the job,
Yep.
and then we become a school teacher, no money. I mean, and we were talking about parents with mental illness, and this psychiatrist stands up and gives his life story, and I cried, and I definitely cried because this is what exactly I was talking about, and he gave an example. So
I know, Basu, I don't know. In this expert series last month, we had Dr. Sinha from Melbourne. You must be knowing him. He gave us a beautiful talk on children of parents with mental illness. Really, it is, I mean, the kind of experiences he shared with us also was, it gives a different approach and gives a different thinking to all of us, how early interventions are so important.
Yeah, and that's what the
Anyways,
symposium we were talking about, Sonia. At the last time, it was FAPMI, and other states it's called COPMI. Children of Parents with Mental Illness is COPMI, and Victoria we say it's FAPMI because we thought it's
please
families.
do come to ANSIPS, and we would love to have you guys
Yeah, I mean,
there and listen
I
to you
think
people.
I think Shabir and Sam is going to have that symposium. I think I'm tempted to come now. And
Josie,
Do come.
the abstracts are still open till the 31st.
okay, let me.
So
I'm not going. I have to go on a house. Oh no, sorry. I mean, Kerala is a beautiful
yeah,
place.
no, it's beautiful. So I'm just wondering if you think from this symposium you have some idea, Josie. Don't hesitate. I'm happy to kind of to help with that.
Yeah, I mean
But I have to, yeah.
this is a work in progress. I mean, it has been about 3 years. I have been started on this, and in awareness, a long way to go, and we will continue to do this. We will continue to do this in ANSIPS. I think that's a platform. I think everybody has to be across. Um, we have to move away from that hierarchical model of thing to flatten it up, like we see in the West. Everybody does their work and very clear about it, and nobody is cross practicing, nobody is challenging the other person. So in a multidisciplinary team, it's very clear. And I'm very clear about it, and because we have worked here and we have seen it, and we have executive director of mental health services, nurses, social workers, psychologists. It could be anyone, and the director of clinical services would work under them. So there's nothing like there's hierarchy here. Everybody has got a role, and it's very clear. And I think Soumya and Shabir, you would agree that that's what happens. So that also has to happen. That means it needs to be a cultural change. Only then that multidisciplinary team will work. Biopsychosocial model will work. I think we can wait if anyone, if one final word from everyone, Shabir, then we'll wind it up.
No, thank you very much. I think I've learned a lot from this.
We all learned. We're still learning. I think that's the good thing. We learn until death, and so we continue to learn. But it's evolving. I think mental health training, mental health practice, mental health interventions are evolving all the time. So, Sonia, any final word?
I think we need more research in the area of mental health, and that can happen only with, if we don't start thinking, we don't start asking questions, we are not going to research. So I feel, like you said, learning should continue. Mental health, what is the etiology of mental health? That always needs to be read more. So let's explore, let's share views, and keep learning more and more from each other.
Thank you, Sonia. And Soumya?
No, I've spoken enough, man.
Okay, thank you. And finally, Gayatri.
Hi, some fireworks going on. I don't know, so I can't hear you all, but it is really nice talking to you all. It's like that amazing experience we feel after a CIP seminar or case conference. After that, we feel that energy to read more, work more. Suddenly, I was like thinking I was postponing to send an abstract to an Asian CBT Congress in AIMS. Then now I'm thinking that, okay, I'll do an abstract. It's really very inspirational moments for me. Thanks a lot for everyone. Thanks a lot
I
for
think
everyone.
Gayatri, you should
Thanks a
take
lot,
the
Josie.
associate membership of the IPS. I think all the mental health professionals should become
Pardon, I
associate
can't
members. And,
actually hear you properly. There are some fireworks going on
yeah.
here.
Thank you very much, friends. It was very rewarding, very brainstorming, and I hope all our viewers have benefited out of it. And it's a working progress. We will continue to do this similar sessions. And thank you all very much. It has well gone over the time.
Thank you.
Yeah. And good night. Bye bye.
Thank you.